Hello, dear colleagues. My topic is early and late postoperative arrhythmias, and I'd like to start off with a scenario. A 6-month-old baby after complete AVSD repair comes to the ICU. And what you can see here is a tachycardia of around 175 beats per minute. It looks regular, and if we look for the P waves, we can see them, but they are not in association with the ventricles, with the QRS complexes. And by eyesight, I would say the P waves are a little bit slower than the QRS complexes. So we have narrow complex tachycardia, heart rate 175. We have VA dissociation with the ventricles faster than the atrium. Now this makes the diagnosis of postoperative junctional ectopic tachycardia, or JET, due to increased automaticity of AV nodal tissue. Be careful, there might be cases where you see a one-to-one VA conduction with JET. So if you're not sure, give adenosine. You might then get AV dissociation with the ventricles marching through and the diagnosis of JET is clear. Or if it's another type of SVT, you might be able to terminate tachycardia. So adenosine is very good in differentiating tachycardia mechanisms in these cases. Now, if you're talking about early and late post-op arrhythmias, the entities are quite different. Early post-op arrhythmias, we're talking about junctional ectopic tachycardia or about AV block, whereas VT or other types of SVT are rare. In late post-op arrhythmias, the prevailing entity is atrial flutter, or something we call intraatrial reentrant tachycardia, followed by atrial fibrillation in our older patients, and also ventricular tachycardia and sudden cardiac death play a role. Sinus node dysfunction is something rare, and also other types of SVT. Starting with early post-op arrhythmias, you see here on the left side a paper from 2006 from the USA, where a 15% risk of early post-op arrhythmias was reported. And there are many factors that influence this incidence: surgery duration, age, bypass time. And what you can see on the right side, and this was from a large study in a center in Delhi, India, the risk within 10 years was decreased from 15% to 7.5%. Again, being JET the most prevailing arrhythmia. This is a more recent paper from this year, but it's from a lower to middle income country, from Pakistan, from a large cardiac center there with 812 children. And in their group, 22.8% developed early post-op arrhythmias. And the type of arrhythmias were quite the same. So JET was really most prevailing. The age groups were different. So they were not able to operate too many infants, as you can see down here. And they were looking for risk factors for arrhythmias. And what they found is that surgical factors and myocardial protection techniques play the most important roles. Surgery duration is important, cardiac bypass time. Of course, the age at operation plays a role too. So probably because we got better and better with these factors at our centers, we're not seeing a lot of early post-op arrhythmias these days. But if we see them, if we see JET, how do we treat it? Now, our protocol says we should do deep sedation, as few inotropes as possible, and do cooling to 32 to 34 degrees Celsius. And there was a nice paper from last year that showed that around 50% of patients respond to these conventional measures and to hypothermia. If we have to use medication at our center, we used amiodarone, but I'm going to show you a paper in a minute. And we sometimes use inverse pacing. I have no personal experience with ivabradine, and in desperate cases you might use ECMO. But the good part is JET resolves in over 90% of cases after 1 to 2 days. Here is one slide about inverse pacing. And the idea is that you take the atrial lead and put it at the external pacemaker in the V connection, whereas the V connection goes to the V via goes to the atrial connection. And what you're getting then is an R-wave synchronized pacing. You sense the V and pace the A. Able to do is to restore AV synchrony. Now, this is a recent paper about ivabradine versus amiodarone in the management of post-op JET. Ivabradine, which is a selective inhibitor of sodium channel, decreases the slope of diastolic depolarization in junctional tissue, and this results in reduced automaticity. And in this study, you can see that on the right, 94 patients were randomized undergoing amiodarone or ivabradine treatment. In the end, what they show is that there was not a big difference. The conversion to sinus rhythm happened a little more often in the ivabradine, 95.8%, versus 93.5% in the amiodarone group. Amiodarone was a bit faster. This might be due to the fact that ivabradine is not given IV, but orally or nasogastric. And no significant drug-related events in both groups were noted. So ivabradine might be a very good alternative to amiodarone in treating these children. Here you can see again what I said. And down here, the time to conversion, which was 7 versus 8 hours. Now, the next scenario. And you see here different forms of AV block. And in the lowest, in the E limb, you see an AV block 3. And this is the other early post-op arrhythmia we have to face. Now for this, we have clear guidelines what to do. And they say that permanent pacemaker implantation is indicated if you have a high degree, second or third degree AV block that persists at least 7 to 10 days. And it's also indicated if AV block late onset is happening, especially if there was a prior history of transient post-op block. Now, there is an interesting paper from this year that looked at the factors predicting recovery of post-op AV block, because these are poorly understood. They had 180 patients with post-op AV block, and in 90 of them, in 70%, there was a return of AV function within 1 to 6 days after a median of 2 days. And the other 38 patients received a pacemaker. Now, interestingly, in 6 of these 38 patients, there was a late recovery of AVN function within 5 to 117 days after a median of 13 days. So what these authors stated was that in 91% of all resolutions happened till day 10 after surgery. And they looked at factors influencing this fact and found that single ventricle physiology, a greater weight, and a shorter cardiopulmonary bypass time were more likely to have a recovery of AV function. So it might be worth to wait 10 days. Now, in summary, early post-op arrhythmias, JET and more, what do we really need for treatment of these arrhythmias in the ICU? And my favorite 4 are adenosine, because it helps you sometimes to detect the mechanism and sometimes to treat the tachycardia. I like amiodarone, but ivabradine might be a good alternative in JET. You need pacing wires if you have AV block, and for the really bad arrhythmias, you should have a defibrillator. All right, so let's go to another scenario. This is a 35-year-old patient with a TGA status post-mustard operation, and this is his ECG. And you can clearly see that there are more P waves than QRS complexes, so the opposite of what we had in JET. And these P waves look like sawtooth pattern. So this is a patient that has a heart rate of 82 beats per minute, and he feels kind of okay. But what he has is, he has cavo-tricuspid isthmus dependent intraatrial reentrant tachycardia, IART. And we should remember, why don't we just say atrial flutter? We should remember that the cavo-tricuspid isthmus in these mustard patients is quite different from normal hearts. And you see in the right picture the creation of the baffle leading the blood from the IVC-SVC to the mitral valve. And you see that most of the isthmus is in the so-called pulmonary venous atrium, and only a small part is in the systemic venous atrium. So if you want to ablate the isthmus in these cases, we have to reach both atria. Now, definitions and terms, because this is sometimes a bit confusing also in the papers. We used to say macro-reentrant atrial tachycardia, which included typical atrial flutter and other well-characterized macro-reentrant circuits in the right and left atrium. And this is where IART falls into. And then we talked about macro-reentrant atrial tachycardias that do not involve the cavotricuspid isthmus and called them atypical or non-cavotricuspid isthmus dependent flutter. And then I would say 10-15 years ago came the term intraatrial reentrant tachycardia. And this is the one we're using most of the time. And this refers to any macro-reentrant atrial tachycardia that does not utilize the cavotricuspid isthmus as a critical pathway for reentry. And nowadays, I guess I would call it cavotricuspid, CTI, or non-CTI dependent, IART, if I talk about tachycardia in these cases. And EART is the most common tachycardia mechanism in adult congenital heart disease patients. Now, this is from the 2020 ESC guidelines for the management of adult congenital heart disease, and it shows us a bit who is in danger or who is the one at risk for arrhythmias, late post-op arrhythmias. And if we're looking into the EART or EAT group, we can see that TGA after atrial switch, mustard sending are the patients that are at most risk for that, followed by the old style Fontanes, the atriopulmonary connections, and then by other entities. If we look for VT and sudden cardiac death, interestingly, again, atrial switch play a role here, and the other patients that are prone for VT or sudden cardiac death are the patients after repair of tetralogy of Fallot. Now, first of all, should we treat medically these IARTs? This is a study from almost 10 years ago with 92 patients, and more than 80% had ART or AFib and were on long-term medication. But, and this was quite disappointing, after 2.5 years, only 45% of patients were free from SVT. Looking into that more, we saw that class 3 drugs are the most effective. However, adverse effects occurred in 22% of patients, mainly with amiodarone, and we all know about the problems with the thyroid. So in the end, these authors concluded that experience with chronic pharmacologic therapy for these tachycardias in adult congenital heart disease has been discouraging, resulting in a growing preference for non-pharmacological options in most centers. And this is where we're going since 10 years, leaning towards catheter ablation. And if we look into the new guidelines, ESC guidelines, we can clearly see that we should control rhythm. Rhythm control is recommended and the preferred initial strategy, but that catheter ablation is recommended as first-line therapy and preferred to long-term pharmacological treatment. Now, going back to our patient, so what should we do? We should take him to the lab and we should try to ablate this. And there are different ways to get access to the pulmonary venous atrium. You can either do it with the help of remote magnetic navigation, RMN, or the alternative is to do a transbathyl puncture. In this case, we did it with RMN, and you can see that we try to ablate the isthmus in the pulmonary as well as in the systemic venous atrium. And what is very nice is that we can integrate our electroanatomical maps of both atria into CTs to get a better idea of anatomy and of where we are. How successful is catheter ablation now for IART? This is a study from Göttingen from 5 years ago with 144 patients with all types of congenital heart disease. And what they showed is that the acute success rate was about 80%, but they had only 17% of all ablations were left atrial ablations, like PVA ablations, like in our mustard patient, and the success rate was lower. They had a low complication rate, but what they saw over a long follow-up of 7.4 years, that there was a recurrence rate of 54%, and 75% happened in the first year after ablation. Now, in this study, there were no data about the long-term success with multiple ablations, but I think that we have to ablate, or it's shown here, that we have to ablate at least half of our patients a second time. And that might depend also on the complexity of congenital heart disease. Now let's leave the atrial flutters, the intraatrial reentrant tachycardias, and talk a little bit about atrial fibrillation, because this is coming more and more. Our patients get older, and the prevalence of atrial fibrillation in adult congenital heart disease is higher than in the total population by a factor of 3 to 10. And adult congenital heart disease patients with atrial fibrillation are younger. Their onset is around 49 years. And interestingly, they progress to persistent AF in 26% of cases after 3 years despite therapy. It's interesting also that often simple congenital heart disease like atrial septal defect is prevailing when we look at atrial fibrillation. Now, does atrial fibrillation have a prognostic significance in our patients? Yes, it does. These are data from a large Korean nationwide registry with almost 4,000 adult congenital heart disease patients with atrial fibrillation. And they compared that to 62,000 adult congenital heart disease patients without atrial fibrillation. And what they found, and what you can see here in the Kaplan-Meier graph, is that patients, female and male, with atrial fibrillation had a significantly lower 10-year survival rate than patients who did not have atrial fibrillation. There are not many data out there about catheter ablation for atrial fibrillation, but this is coming more and more. This is a smaller study from our center with 57% of patients. And in our cohort, it played a role if atrial fibrillation was paroxysmal or persistent, because the results after multiple ablations were much better for paroxysmal AF with 82% compared to 48% in the patients with persistent AF. This is just to give you an idea about such a patient, 74 years old, male, status post tetralogy repair, and with an ASD occluder. He had a stroke, he had paroxysmal AF, and then since November 2019 had persistent AF, had several cardioversions, and was planned for an ablation. We're always doing a pre-procedural CT scan because we can overlay that with a 3D mapping system. And what I wanted to show you is that the ASD occluder is sometimes a problem, but we often manage, and this is at the lower part of the ASD occluder, to do a transeptal puncture. And for this, the CT scan is very nice because we can kind of plan and see how much space there is. In the lab, we have a lot of high-tech tools for atrial fibrillation ablation, sheath with sensors. You can see that here, a multipolar mapping catheter. We do have contact force ablation catheters. And as you can see here, we can integrate the map into fluoroscopy and do automatic annotation of EGMs, of voltage and morphology. One topic I just want to raise a little bit is oral anticoagulation for the intraatrial reentrant tachycardias as well as for atrial fibrillation in these patients. And it's important to say that direct oral anticoagulants, which is apixaban, rivaroxaban, edoxaban, dabigatran, seem similarly safe and effective in the absence of mechanical valves or severe mitral stenosis in these patients. And there is a nice paper from the Munich group from Claudia Pujol, and they looked at 215 patients. And what they found was that the major bleeding rate of 3.1% per year and thromboembolic events 0.7% per year was very comparable with vitamin K antagonists with a bleeding event 4.1%, thrombotic risk 1.4%. And on multivariate analysis, only renal failure was an independent predictor for bleeding risks. And they did not identify risk factors for thromboembolic events. So these new anticoagulants seem effective and safe in adult congenital heart disease. Well, this is just to show that the majority of these patients had atrial fibrillation or flutter. And then I'd like to come to the last scenario. And this is a 22-year-old female patient after double outlet right ventricle repair. And she had a resection also then 3 years later in the right and left ventricular outflow tract. And in 2007, she had her first hemodynamically relevant VT. And at that time, we did not talk so much about ablation and did not dare to leave her without an ICD, which she got. And then in 2010, we tried our first ablation in her in the RVOT, and we kind of followed the scheme of Katja Seppenfeld and her groundbreaking work about the tetralogies and the macro-reentrant tachycardias in these patients. And they identified isthmuses, isthmus 1, 2, 3, 4, that were kind of necessary to create those macro-reentrant tachycardias. And these isthmuses were the target for ablation. And in this patient, we had done 3 ablations in the end, and we were very disappointed that 6 months after the last ablation, she came back with recurrent VT. And she said, well, I want a 4th ablation. Please look again. I do not want to live like that. And interestingly, at the 4th ablation, we got this VT. And if you look carefully, she has a right bundle block pattern in the chest leads, and she had an inferior axis. So we induced this VT during the EP study and thought, well, this looks like LVOT origin. The patient was hemodynamically stable, so we kind of went to the left side of the heart. And you see here that we're mapping the tachycardia, and we found the earliest activation zone in the lateral LVOT below the aortic valve. And we ablated in this area with an irrigated tip catheter, and since then she had no further tachycardia episodes. So you see that in such a patient, complex tachycardia can happen. So never give up. All right, there are not too many data about catheter ablation in VT in adult congenital heart disease out there. This is a smaller study, 21 patients with 14 patients with reentrant VT through an electroanatomical isthmus and 7 patients with a focal mechanism. And you see here that they were quite successful. They had a documented VT recurrence after ablation in only 14.3% of their patients, with most of them being tetralogy of a low. So nowadays, I guess ablation is the way to go, even if it needs more than 1 ablation in these patients. And this, I don't want to go through this. This is just from the very new 2022 EC guidelines for the management of patients with ventricular arrhythmias. This is for the adult congenital heart disease patient. Go into that for yourself. You'll find that you first have to evaluate the anatomical abnormalities. You have to see if there is residual hemodynamic causes of VT. And then it's a nice algorithm to find out, should you do catheter ablation first? Should you place an ICD? But I guess this discussion is ongoing. So I'd like to start with this. I hope I could give you a nice overview over the early and late post-op arrhythmias. And I thank you for your attention.